scenario is described to understand this. A 50-year-old housewife who had been on anesthesia for her joints pain since many years presented with breathlessness and exertion, an abdominal distension and swelling of the feet for the last 6 months. She had the history of the jaundice 5 years back and had 3 cesarean sections in her obstetrical history. The temperature was 99.4, pulse was 110 per minute. It is a bounding pulse because she is anemic patient, and blood pressure is 100/55. Pedal and sacral edema was positive. Liver span is 7.4 centimeter, which is small liver. Mild splenomegaly is there with the shifting dullness in abdomen, means ascites is present. The investigations revealed that hemoglobin is 7.7 gram. She is anemic. MCV 76. It is normocytic anemia, and random blood sugar is 121, which is normal. Total bilirubin 2.7, which is higher. Direct is 1.9, which is more than the indirect, but it is a mixed type, both direct bilirubin and indirect bilirubin. It is called hepatocellular type of jaundice. Hepatocellular jaundice. ALT was 88, is higher. AST was 110, which is higher. Alkaline phosphatase 298, which is higher. Gamma GT 88, it is higher. That is, it is obstructive element in there. Cholestasis is there. It indicates cholestasis. Albumin is 2.2, normal is 3.5, it is much lower down, and PT-INR is 1.3. The questions are, they list the differential diagnosis. How will you further investigate the case? What is the most probable diagnosis? Now, how will you manage this case? Now, soft data here is a middle-aged housewife. She used NSAID for the polyarthritis. There is low-grade fever, tachycardia with bounding pulse, hypotension, and macrocytic hypochromic type of anemia is present actually. It's slightly macrocytic, otherwise it is normocytic. But 76 is not much lower down. Heart data is exertional dyspnea with abdominal distension, which is a progressive pedal sacral edema, and past history of the jaundice and the multiple surgeries where blood transfusion probably was done, and liver span was 7.5 centimeter, which is lower down. It should be more than 7.5. Now normally 11 centimeter is there. If it is less than 11 centimeter, it means that the liver span is lower down. 7.5 centimeter is very small liver. Splenomegaly with shifting dullness. Predominant direct hyperbilirubinemia, although the mixed type is there. The increased liver enzymes and the PT-INR is increased, which is a very important crucial test in the liver function test. Most crucial test is PT-INR. After the progressive disease, then ALT is the best test to be do. We do usually ALT. But in this condition, the PT-INR is increased, means that liver function has been grossly disturbed. But the differential diagnosis is, it may be hepatitis, acute hepatitis, chronic liver disease, pre-cirrhosis, portal hypertension, and cirrhosis. I have described these terms previously in my last lectures. So these are, here in this scenario, there are signs of portal hypertension and cirrhosis. I will repeat what is cirrhosis. I have said in my last lecture, please remember this thing, that inflammation of the liver cells plus destruction of the liver cells plus regeneration of the liver cells by fibrosis plus regeneration of the hepatic cells in nodular fashion. It should be in a nodular fashion, micro or macronodular, leading to the multi-system involvement and has syndromic type of features, means different systems are involved. Every part of the body is involved It is a multi-system involvement, and nothing is left in the body which is not involved. The cirrhosis should be very clear than the hepatic fibrosis. Hepatic fibrosis, there is nothing but only fibrosis. But in cirrhosis, there are 3 or 4 things should be present. Then it is no cirrhosis. It is known as cirrhosis. Etiology, it is cryptogenic. Cryptogenic means that the etiology is not known clearly. It may be associated with deficiency, or it may be overeating of cassava, which is a fruit-like thing, which was eaten in India at one time, and it leads to cirrhosis of the liver. Alcoholic chronic viral hepatitis, I have said B, C, B with D. This will cause, and a type of hepatitis E, a variant which can cause chronic viral hepatitis, which can lead to the cirrhosis of the liver. Only one thing is left in this, which is to be remembered, that is, chronic hepatitis should be there before cirrhosis. There is only few conditions in which there is no chronic hepatitis. Without chronic hepatitis, there is direct involvement of the liver. For example, we will do in the next discussion, it is coming now, the drugs induced. There are a lot of drugs which can cause the problem of the liver. Most culprit drug is the paracetamol in the larger doses will cause cirrhosis of the liver. But other drugs are also very important, and they are the NSAIDs. They are macrolides which can cause PBC, primary biliary cirrhosis, cardiac cirrhosis, Wilson's disease can cause cirrhosis. Alpha-1 antitrypsin deficiency can cause cirrhosis. Wilson's disease and alpha-1 antitrypsin deficiency will not cause chronic hepatitis. It will cause directly cirrhosis of the liver. Now, autoimmune hepatitis, which is a chronic type of hepatitis, and the primary is chlorine cholangitis. Now, cirrhosis causes the multi-system illness. Why it occurs? Because of the hyperdynamic circulatory state. And why it occurs? Because of the portal hypertension. Why portal hypertension occurs? Because of the compression of the hepatic venules, which is inside, portal tracts, which are badly compressed by the fibrosis and by the regenerating nodules. They are compressing it. The intrahepatic pressure is much increased in this condition, and it reflects back on the portal vein, and it will cause the portal hypertension, which is normally 15 to 25. It is millimeter of mercury of water. It is raised in this condition. It has got an important role in all the systemic manifestations of the cirrhosis. What is important is the portal hypertension. If there is portal hypertension, it occurs, it will lead to a hyperdynamic circulatory state. So water retention occurs in this condition, and the sodium retention occurs in this condition, and it will also cause the systemic vasodilation and blood volume expansion. Vasodilation and hyperdynamic circulation in cirrhosis will cause the splenic vasodilatation. Portal venous inflow is increased, and it will cause the varices, the esophageal varices. It will also cause the peripheral vasodilatation, and the sodium and the water retention occurs, and which will cause the ascites. There are a lot of theories of ascites in cirrhosis. It is one theory which is written, which is in front of you. The second thing is it will cause the renal vasoconstriction and hepatorenal syndrome. On the other hand, vasodilatation occurs peripherally, and the renal vasoconstriction occurs. Try to understand this important point. There will be high output cardiac failure because of the reduced peripheral utilization of oxygen. The heart rate will be increased, and the patient will go into the high output cardiac failure. Pulmonary vasodilation occurs because of nitric oxide, and arterial hypoxemia and hepatopulmonary syndrome will occur. We will discuss on the next lecture. Cerebral vasodilatation will cause brain edema and hepatic encephalopathy. What is the clinical manifestation of cirrhosis? And manifestation is already mentioned out. That is, the peripheral stigmata of the disease has already been outlined, and I have already discussed it. The complications occurs because of the portal hypertension. And portal hypertension will cause the visceral hemorrhage and ascites, and it will cause the hepatorenal syndrome and spontaneous bacterial peritonitis. And the function of the liver is disturbed. Liver insufficiency will cause encephalopathy, jaundice, deficiency of hormones, deficiency of vitamins, deficiency of the trace elements, the disturbance of the carbohydrate metabolism, disturbance of the protein and lipid metabolism. What is the natural state of cirrhosis? It is the chronic liver disease. I have already mentioned out in my previous lecture. It is a chronic liver disease, it means that chronic hepatitis. It will cause the compensated cirrhosis. It means the liver is damaged already, but to such an extent that patient can survive, and the therapy can be given, and it can be reversible to some extent, so that the life can be expanded to more than 5 years, 6 years. But if there is decompensation occur, the patient will not survive. In few weeks to few months, the death will occur. Because of the complications, I already said that visceral hemorrhage, ascites, which is refractory encephalopathy, jaundice, which is mounting jaundice. Decompensation shortens the survival. Look this chart. The decompensated cirrhosis, the lifespan is small. The all patient with cirrhosis means compensated cirrhosis as well. Their life is good. They can survive up to 9 years, 10 years. I have seen a patient of more than 15 years with cirrhosis of the liver. How do you make diagnosis of cirrhosis? By presentation, clinical presentation, clinical workup. And secondly, if you want to prove it, you go for the liver biopsy and do it. Because liver biopsy, nowadays, the patient is not, comfortable, and it is not consented also. The other way of diagnosis should be achieved, like liver function tests which are disturbed, liver damage tests, the enzymes are increased. Ultrasound will show you the portal vein enlargement, 1.4 millimeter if it is all right. If it is more than 1.4 millimeter portal vein dilation, it means that portal hypertension is there. And the liver ultrasound will show the normolarity and decrease in size. And etiological diagnosis of hepatitis B, C, D, etc. can be done. Liver biopsy, it is actually a very difficult procedure nowadays. The patient is not ready for it. But we will do in certain cases. And surveillance tests, alpha-fetoprotein, sonography, endoscopy, paracentesis, creatinine, etc. Now, the diagnosis of cirrhosis is histological diagnosis. But you cannot do it because the patient is not consented, not comfortable. In whom we should suspect a cirrhosis of the liver? Any patient with chronic liver disease. can go into this disease. Physical examination, the peripheral stigmata is there. Muscle wasting was spider angioma, palmar erythema, the clubbing, palpable left lobe of the liver, small liver span, splenomegaly, and signs of decompensation like jaundice, ascites, and hepatic encephalopathy. In whom we should suspect cirrhosis, again lab will show you the hypoalbuminemia, albumin globulin ratio is much disturbed. PT-INR is a very sensitive test. It is increased. High bilirubin, portal hypertension will cause the splenomegaly, and splenomegaly will cause hypersplenism, and there will be thrombocytopenia. AST-ALT ratio is more than 1. AST is more increased than ALT in most of the cases. In whom we should suspect cirrhosis, again the imaging studies will show you in cases where there are no symptoms, your examination is not good. Liver spleen scan, CAT scan will help you in the diagnosis. This is the CAT scan in the cirrhosis. And confirmatory liver biopsy is not always necessary in cirrhosis. It can be done by clinically very easily and by lab tests very easily. Now this is the diagnostic algorithm which is in front of you, that the chronic liver disease, if this is there, is a reversible hemorrhage or ascites, hepatic encephalopathy, there is no, but then you got physical findings other than that, like splenomegaly or peripheral stigmata other than that, and lab finding are there, thrombocytopenia, etc. is there, then you go for the liver biopsy, which is not necessary for the diagnosis. It will be diagnosed as cirrhosis of liver. You will not do the liver biopsy. Radiological findings: small nodular liver, intra-abdominal collaterals, ascites, splenomegaly, collateral shift to the spleen and or bone marrow. Liver biopsy cannot be done in this case because it is already diagnosed by the radiology. In this patient, if there is directly you see the uricis, esophageal uricis, it means portal hypertension. If the ascites is there and it is proved it is definitely it is transvitative type of ascites, then diagnosis has been done. Hepatic encephalopathy is the sign of the cirrhosis. So there is no need of liver biopsy. Management is in this case, etiological management is may be possible. If hepatitis C is there, chronic hepatitis C or B, and it is compensated liver cirrhosis, then you can try. A prophylactic treatment can be given in these conditions so that the hepatic encephalopathy does not occur. Dietary measures should be there. The low protein diet should be advised, high carbohydrate diet, low salt diet. These are the things should be done. And we will give the drugs specifically for the reduction of the ascites and the peripheral edema, the diuretics, that is the what is known as the alloxan and furosemide, etc. And we give the laxatives to this patient so that constipation do not occur, which constipation will cause the hepatic encephalopathy. If the repeated attacks are there, the liver transplantation is the last option which you will do. Otherwise, you can do the bridge management, and that is the surgery can be done. That is, you will anastomose the portal vein with the systemic vein to reduce the portal pressure. It is possible like that. The next lecture is on the complications. In this, the complication of the cirrhosis is esophageal uricis, portal hypertension, ascites, spontaneous bacterial peritonitis, hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome, and coagulopathies. Now this will be discussed next part 2. This is part 1 which I have concluded now.